Good evening. This is our last live stream. We've had a wonderful week so far, and today I get to talk to you about paediatric radiology. I've selected a couple of cases. There should be 5 cases in the page so far, so hopefully you've been able to look through them. If you haven't been able to look through them, that's absolutely fine. We'll go through the cases, and as we do, pop some comments in the chat. I'll answer them as we go along, and then we can round off the session with some more general questions afterwards. It's been a beautiful day here in the UK in Edinburgh, and the sun's just setting. I can see from the chat that we've got people from all over, so let's get going. Our first case is of a lad with a football injury. He's coming to ED with a hyperextension injury, some direct trauma. He can't weight bear. To be honest, most 14-year-old boys, when they get injured at football, can't weight bear either. You've seen them rolling around on the floor. But this guy gets his X-ray, and this is the X-ray that I showed you in the page. So what do we look at? We're going to look at the AP first, and then we'll go to the lateral in a minute. Whenever I'm looking at an AP in a kid, what am I looking for? I'm looking for joint space, as we do in everyone. I'm looking for normal. What are the bits that we struggle with? Well, often people get confused by lines and physes. So the lucent lines, distal femur, proximal tibia, proximal fibula. Sometimes they get caught out by this area of irregularity down here on the medial portion of the proximal fibula. That's just the attachment of the interosseous membrane. It's nothing to worry about. If you're watching the live stream from Matt Skalski on Monday, you will have seen him drawing one of these, or at least copying it from another X-ray. This lad's got a large non-ossifying fibroma on the medial portion of his proximal tibia as well. We know it's that. It's got classical appearances. It's cortically based, eccentric. It's got nothing to do with his presentation, needs no further examination. Can we see why he's sore on the AP? We can't. But you've probably noticed already, just from the thumbnail, that something is going on this lateral. We're going to get to that next. So on the lateral, there is a huge suprapatellar effusion. We are looking for this prefemoral fat sitting here, and the little triangle of fat just above the patella. And we're looking to see that fat being separated. And as it separates, that's because fluid has built up into the suprapatellar pouch. That's in continuity with the rest of the knee joint, and we can see some increased density down here as well. The patella is also sitting a bit too far away from the distal femur, all of which we'd expect with this size of fusion. If you see this size of an effusion in a child, there's always something going on. And so we need to look for bony abnormalities first, and then we need to go looking for other issues. And actually, if we look closely in the joint space here, we can see what the problem is. It's this triangle of bone here. This is the attachment of the ACL. It's one of the tibial spines, and it's been pulled off. If we go back to our AP, it's completely invisible. You cannot tell that there is a fracture through the tibial spines on the AP. The tibial spine attachment of the ACL is a really good place for an avulsion to happen. In kids, we usually see avulsions. That's why they have all those ankle injuries with fibular avulsions or medial malleolar avulsions. They get avulsions from all sorts of places. And it's because the attachment of the tendon or ligament onto the bone is actually stronger than the bone itself, and it just gets pulled off. And so here we're left with the adolescent equivalent of an ACL injury where the tibial spine's been pulled off. The good thing about this is that actually for this kid, all he needs is an extension cast and a cylinder cast. He doesn't need an operation. He just needs to rest and have that in a cylinder cast with relatively frequent changes as the swelling goes down. That will attach back onto the tibial plateau and everything will be absolutely fine. You can do a CT, and that's what we did in this case. It shows you the avulsion nicely. It confirms that it's just a simple avulsion. There's no other injury. The fracture isn't more complex than just an avulsion. And it just helps everyone know that in a cylinder cast, everything's going to crunch back down into where it should be, and we don't need to do anything else. Do not do an MRI. This will look like a complete dog's dinner at an MRI, and everyone will get very excited and want to do things. This child needs absolutely nothing doing. He just needs a cast and conservative management. We can see down here his benign non-ossifying fibroma as well, sitting on the cortex that we saw on the plain film. So that's our first case. So we're going to look at number 2. Case 2 is a lad who's got failure of complete extension. So that last case was an acute presentation with an injury. This is a non-acute presentation. The orthopedic surgeon says it doesn't feel like a pseudoblock. So a pseudoblock is essentially a block that the child presents with, but actually if you put them to sleep and examine them under anaesthetic, there's no block there at all. There are a number of reasons for it, but the orthopedic surgeon doesn't think it's that. So they think it's something real. And so we go on and we do an x-ray. So again, same things we're looking for. We're looking for patellar, we're looking at the physes. These are the things that freak people out if they're not looking at films regularly. This child has also got a little fibrous cortical defect in the same location as the last child. Remember that fibrocortical defects and non-ossifying fibromas are cousins of each other. It's just the size that's different. So what's the abnormality here? Well, if we trace the cortical margin of the distal femur on the lateral side and then trace it across to the medial side, we see a large area of lucency with central areas of increased density. And this is what's causing the block. On the lateral, we can see this is it here, this really large sort of crescentic area sitting just in the subchondral bone, right up against the cortical margin. So what is this? This is an osteochondral defect, or osteochondritis dissecans, sometimes and probably more correctly called juvenile osteochondritis dissecans, because it's slightly different from the osteochondritis dissecans we see in the older population. What are we going to do? We're going to do an MRI to further assess this lesion and work out what type it is, what grade it is, and help the orthopedic surgeon decide what to do next. And so we've got a bunch of sequences here. We have got some fat suppressed sequences, fluid sensitive fat suppressed sequences, so either a STIR or a PD FATSAT. We've got some T1 as well, and then there is a volume heavily T2 weighted DES sequence, which is really nice for assessing these. On the T1, we can see that the lesion is here and looks very similar to what we saw on the X-ray, predominantly low signal on T1 extending all the way up to the cartilage. This is cartilage here, this bit here is cartilage, and this is all marrow. Here we've got a little triangle of meniscus, and the cartilage extends all the way across the bottom of the condyle here. And one of the things we want to do is find out whether the cartilage is in continuity or not. Really important for the orthopedic surgeons. We can see that the lesion is actually not as well seen on the MRI as it was on the plain film, but there's this edema at its base, confirming that it's definitely real and definitely causing some sort of reaction in the adjacent marrow. On the DES sequence, we can see that the marrow signal, there are little areas within the lesion that have that same marrow signal. And those are the areas on the X-ray that look like little fragments of bone within the lesion. And as we follow the cartilage around all the way across the fibrous, the osteochondral defect, we see that it's in continuity, and that's really important. So these lesions, the natural history of them is that they develop. We're not entirely sure why. There may be some genetic predisposition, some repetitive microtrauma, a whole host of other potential etiological factors. They develop and they may either heal or not heal. If they don't heal, you end up with some really soft bone, a bit like scrambled eggs sitting underneath the cartilage. And over time, that cartilage starts to move and then it fissures. With the fissure, you then get some fluid tracking into the bone behind the lesion. Over time, that fissuring will continue, completely separate out the lesion, and then you have a loose body. And that's essentially the grading system in osteochondritis. So we're looking for cartilage continuity, any evidence of fluid behind. Now, what we mustn't do is look at this and think that this is fluid. It is not fluid sitting behind. Let's just double check. Do we have fluid in the knee? This is fluid back here. This is how bright the fluid would need to be. So there isn't fluid here. It's just a little bit of high signal at the base of the lesion, and that's normal on the DES. So don't overcall that. The surgeon has two options: treat it conservatively or go and micro drill it. And the micro drilling essentially allows them to drill up through the base of the lesion, through the cartilage, through the lesion, into the bone, and try and promote some neovascularity from the condyle itself back into the lesion to promote healing. And that's what this boy had. So here's some photos from the arthrogram. So here's one of the probes just sitting underneath the menisci. So they went in and obviously double checked the menisci were right. And then here we have a probe actually poking on the bit of bone or the bit of cartilage that's overlying this osteochondral lesion. And that cartilage is completely intact as it was on the MRI. But as the surgeon pushes, he's feeling that actually the soft bone, those scrambled eggs sitting underneath the cartilage, are deforming and being pushed away. And so then went on to micro drill up through the lesion about 10-15 times. And that's a 1 millimeter heavily zoomed up K-wire essentially being used as a drill to drill the lesion. This is another case of a similar lesion, 11-year-old. He's actually had recurrent patellar dislocations, and that repetitive microtrauma has ended up causing a large osteochondral defect here anteriorly within the distal femoral epiphysis. Just for later, worth noting that we have very wide range of ossification in the tibial tuberosity. You can just hook that away, one away for later. On his MRI, what do we see? We see a very similar picture, cartilage intact over the top. But what's interesting is actually the cartilage slightly deforms as we go through. So there's a slightly wavy appearance to the cartilage that's been pushed down and back into this really soft bone that's been sitting behind it. So we've seen an acute presentation, and then we've seen a non-acute presentation, but with a condition that needs to be really considered quite carefully so that the orthopedic surgeons can make the best decision going forward. And in general, in pediatrics, usually less is more as far as intervention from an orthopedic surgeon is concerned. If you can get away with not getting them to cut the child, that's usually good. So our next case is not actually an orthopedic patient, they're a rheumatology patient. They've got oligo-JAA, so they've got one joint involvement, it's their left knee, and they've got JAA. So they will usually then have had either a joint injection, if it's just a single joint involvement, potentially with some steroids, and then depending on how they've responded to that, they'll then have been put onto some other treatment. So she's had a recent fall in basketball, pain and minor swelling. So is this her JAA? Is this trauma? And so in these cases, what we'll do is give contrast. So similar to the last case, we've got a T1 weighted sequence. We've got some fluid sensitive fat suppressed sequences, but we've also got some post-contrast sequences and then a pre-contrast to compare. And just like in any other imaging, if you're going to be doing some MRI with contrast, only change one thing. So if you're doing axial post-contrast T1 FATSAT, do an axial T1 FATSAT pre-contrast as well. Try not to do a T1 pre-contrast without fat suppression and then follow it up with a post-contrast with fat suppression, because then you're changing two things, everything looks completely different, and unless it's barn door, it's tricky. So what are we looking for? We are looking for any evidence of JIA. So that would be effusion, synovitis, and edema. Best place to look for synovitis is the post-contrast. And as we scroll through this knee, down patellar tendon, up towards patellar, this is normal cartilage signal. There's a little bit of enhancement around the synovium, that's completely normal. You're allowed a little bit, and there really isn't synovitis here. On the fluid sensitive sequence, there is a little bit of fluid up in the suprapatellar pouch, maybe a touch more than you might expect for normal, but not too bad. What we find is as we scroll back through again, we've got a big chunk of cartilage missing, and actually it's best seen on the T1. Here it is, big chunk of cartilage. Let's look with a zoom. So bone marrow, dark line of interface between bone marrow and cartilage, and then it comes down and there's a big chunk missing here. And then there's low signal in the T1 of the marrow. And on the fluid sensitive sequence, that is obviously edema. Now what's interesting is there's no edema in Hoffer's fat pad. You look around, you cannot see that big chunk of cartilage anywhere. And so this is likely a chronic area of cartilage loss in a child with JAA, who's then presented with a knock to the knee. And this is not the reason that she's presented. This is just something that we found. The important thing is though, that once you've said there isn't any evidence of synovitis, go looking for other things, because these children do have cartilage loss, they have cartilage thinning, they have areas of cartilage damage, and it's really important, especially if they've got a loose body, that we tell the referral clinicians that that's what's going on, so they can get it dealt with. Her x-ray was completely normal, as you might expect. Interestingly, actually, I recently uploaded the next set of imaging for this patient because she comes back years later with knee swelling and a flare of her JAA with widespread synovitis. So our next case, 11-year-old knee swelling on and off for months, pain and incomplete extension, red and hot, no infective symptoms. So you get this clinical history on the card, you look at it and you're thinking, well, what are we going to do next? Are we doing an x-ray? Are we doing an MRI? You'd probably do an x-ray first. I think we've probably just got the MRI and that's what I showed you or gave you to look at beforehand. Knee swelling for months. So we're not thinking acute problem. Pain and incomplete extension. Incomplete extension and block to extension can happen in lots of different conditions. Red and hot, but there are no infective symptoms. So presumably that means there are no systemic evidence of infection, but we know that infection can occur and not have infective symptoms. So we've got all those options, and Miguel on the chat is saying ultrasound. He is absolutely right. That's what we go for first, but we haven't uploaded it for the case. What do we see on the ultrasound? Again, same set of sequences, T1, fluid sensitive, fat suppressed sequences, and then some post contrast. Let's go for the post contrast first. No, let's go for the stir first. The stir is going to show us fluid. And as we scroll to the top, we see a large area of increased signal on this, which is making us think of fluid. And as we scroll down, there's also that same increased signal at the back as well. If we look through on the T1, we'll see that the cruciates are normal, the collaterals are normal, the menisci are normal. There's no significant bone marrow edema. I'll come back to talk a little bit about that in a minute. But what I want to do first is show you the T1, which I flashed up at the start there, because what is very difficult to see on the stir is that the areas of high signal on the stir are made up of two separate areas, because this all looks like fluid, and if you didn't have any other sequences, you'd probably just call this fluid. But actually, the fluid here is dark. The synovium is enhancing around the outside and thickened. Do you remember on that previous case we saw there was enhancing synovium, but it wasn't thickened? Well, this synovium is thickened. This is synovitis, and this is JIA as well, so juvenile idiopathic arthritis. Here it is on the SAG, large joint effusion extending into the suprapatellar pouch. Do you remember at the start I was talking about the prefemoral fat? Well, there's the prefemoral fat, and there's that little triangle of fat that's just above or just behind the patellar tendon, or the quads tendon, sorry, sitting on top of the patella. And those two things should be sitting right next to each other. That's what we saw on that X-ray at the start. And now we see widespread thickened synovitis extending down into Hoffer's fat pad, extending posteriorly as well. So JIA. Miguel with his ultrasound would have seen effusion. He might have seen the synovitis as well, especially if you put Doppler on. Remember as well I was talking about edema at the start? There is a bit of edema here, isn't there, in the medial femoral condyle medially, and edema is one of the features that we see in JIA. One of the things that people get very confused about in pediatric MRI of the knee is the marrow edema that occurs. There are lots of causes for marrow edema: tumor, infection, trauma, reactive, but one of them is physiological. And as your red marrow converts to yellow marrow, you have this very weird at times marrow edema. It's often in linear striated patterns, extending through the metaphysis and then stopping at the physis. You shouldn't see it crossing over into the epiphysis. In the epiphysis, they're actually often sort of transverse. Again, we see it here, and we see it in the tibia as well. So don't get caught out by seeing this physiological edema and calling it abnormal. It's just where they are in their growth. So, case 5, and I think our final one. Generalized leg pain, specifically right ankle pain, stopping activities at school and requiring non-involvement in school games. So she's got a little letter from mum saying that she can do it because she's sore. And she's got ankle pain on this request, but she's got knee and ankle pain and swelling. And so we've got a coronal stir of the whole of the legs. And just compare that edema that we saw in that last case with the edema that we see here. You know, widespread, confluent, really bright edema in the metaphysis extending over into the epiphysis. This is bilateral, it's symmetric, it's not just affecting the distal femora, it's actually affecting the proximal tibia as well, and the proximal fibula, and also down into ankles as well, so distal tibia and fibula. So when you've got widespread edema, symmetric, there aren't that many things that cause this sort of appearance. multifocal infection would be very odd to cause this kind of appearance. So you might be thinking about that. You might be thinking about cancer. This doesn't look like standard Mets, so we might be thinking about something like lymphoma or potentially leukemia. Again, bit of an odd presentation. Top of my list is CRMO, so chronic reactive multifocal osteomyelitis, which is a rubbish name because it doesn't always present chronically. It's not necessarily reactive. It doesn't have to be multifocal, and it's not osteomyelitis. So this is actually an inflammatory condition and presents with bilateral, often symmetric edema, often near the joints. There are some bones that get affected more than others. So acetabular roofs, nice place for CRMO to go. Medial clavicle, it loves the medial clavicle and nothing else does. So if you see medial clavicle, think CRMO. And where else? Spine. It loves the spine as well. So an older child with vertebra plana or bone marrow edema in a vertebral body, it's really worthwhile thinking about this as a differential. How certain can we be? Well, it's kind of a diagnosis of exclusion. So we often end up having to do some sort of biopsy, especially in lesions that don't look typical, i.e. the medial clavicle, and maybe not symmetric. But in a symmetric patient like this, with nothing to point us towards infection, no evidence of a leukemic or a lymphomatous picture, then CRMO becomes our diagnosis. And just to highlight that often these x-rays can look normal. They may have hyperostosis, and so they might have hyperostosis, enlargement and sclerosis, but oftentimes they look normal. I would always, though, get an x-ray with my joint MRI. This is the more classic appearance of CRMO. I thought I'd put this one in as well. So this is a 10-year-old girl with left-sided clavicular swelling and pain, arm numbness at times and paresthesia, no vascular symptoms. And what do we see? Well, actually, if I put this up in a Viva for my trainees as they're approaching their 2B exam, I don't give them any history, and it's very easy to walk past the fact that this clavicle here is way bigger than this clavicle. So the left medial clavicle is much bigger than the right. And it's not just bigger in its bony extent. If we do an MRI to look at this, then what we see is a whole host of edema around about the medial clavicle too. So the clavicle is expanded, there's subperiosteal new bone formation, there is edema around the clavicle as well because it's a really highly inflammatory condition. And so these patients should not be looked after by the orthopedic surgeon. This child was. And so as radiologists, it's our job to point these children in the right direction. So like in the previous case, if we've got a rheumatology patient who needs to see an orthopod, it's our job to make sure that the rheumatologist knows that. In this sort of case, the orthopedic surgeon needs to know that this child needs to go and see a rheumatologist. These children end up in orthopedic clinics, they end up in oncology clinics being investigated for cancer. And so you must think about this differential to save some of these children from months and months and months of repeated imaging, sometimes surgery, and sometimes some potentially mutilating surgery. This child, because of the pain and swelling, they were considering removing a portion of this clavicle because of the fact it was causing neural compression. The rheumatologists will treat them, usually with pamidronate. It dampens down the inflammatory process. Sometimes they'll use some methotrexate as well if that pamidronate doesn't work. You can't reverse the hyperostosis that's happened. You can't reverse the bony expansion. As we can see here, this clavicle ended up being huge. But what you can do is switch off the inflammation. And so if we look at her follow-up MRI, Yes, the bone is enlarged as we saw in the x-ray, but there's none of that edema around about it. So CRMO is I suppose one of the conditions that I see often in patients when nobody else has thought about it. And increasingly we are getting these patients to the right people, which are the rheumatologists, to get treatment, which is really simple to do, but it just needs us to think about the differential. So that's us as far as the cases. And what we did have was some questions that have been submitted. So I was going to answer these, and then we might throw it open to the chat. I haven't seen any questions coming through as yet, but what we'll do is we'll answer the 2 questions that I've got, show a couple more cases, and then I will probably grab a drink, and then we'll have some question answering if there are any questions in the chat. So the question here was, how can we differentiate between septic arthritis with osteomyelitis and a simple uncomplicated transient synovitis? So we see loads of these. In fact, when I started at Edinburgh, they would all get ultrasound, and it was nuts. You would have days where you just had many kids getting ultrasounds for query transient synovitis, query osteomyelitis. And that's not good for anyone, because you have a child with a sore hip or a sore knee. They get seen and clinically assessed. They get bloods done and they get an ultrasound. If the ultrasound shows an effusion, we rely on the blood test to work out whether it's infection or transient synovitis. If the ultrasound doesn't show an effusion, we rely on the clinical examination and the blood tests to make a decision. So actually the use of imaging in these children really should be limited to those with red flag symptoms where actually these probably aren't the diagnosis, or ones who have ongoing symptoms. So maybe a transient synovitis that they rest in and suggest they get brufen, and then comes back 2 weeks later and they still haven't got quite through their symptoms. Then it's worthwhile doing an ultrasound to say, yes, they've still got an effusion, it's going to be a little bit longer, or no, they don't have an effusion, maybe we should be thinking about something else. I've got a picture here of the commonest type of imaging we do for transient synovitis, query septic arthritis, which is actually hip ultrasound, not knee ultrasound, but the same principles apply. In hip ultrasound, remember, hips for effusion, very different for hips for DDH, completely different view. Here we're doing a view with the ultrasound probe pointing in the same direction of the femur, centered over the proximal femur in the midline of the bone anteriorly. And what we see is epiphysis and metaphysis, beautiful physis there with cartilage over the top. And then the capsule is actually quite a thick structure, so you're allowed to see that. And then you're looking for the dark area here, which is effusion. Got a nice one there to compare the two. So effusion here on the symptomatic side. You can measure this distance, but actually looking for the effusion is a much more sensible way to approach it, I think. You do the same in the knee. What are the things that you can do to tell those two apart? Some people say that you look for debris within the effusion, and that will make it more likely to be infective. That's true, but you can also have debris and echogenic material in a non-infected transient synovitis hip or knee. So I would push it back to the clinicians, have a good relationship with clinicians, talk to them about what the patient looks like, what do they think's going on, what do the blood tests show, and again, try not to do the imaging unless you really need to. And then we had a question about what are the good ways to distinguish Osgood Schlatters, Syndig-Larsen, and patellar avulsion. Those two diagnoses are definitely something that you need good dictation for, because I can never remember how to spell them, and voice dictation makes life much easier if they get it right. So Osgood Schlatters and Syndig-Larsen are repetitive strain injuries, repetitive tug injuries at either end of the patellar tendon, Osgood Schlatter distally, where the patellar tendon inserts into the tibial tuberosity, and Sinding-Larsen, where it inserts into the patella. So again, this is one of the situations where I don't think that when we do an x-ray in these kids, we're actually looking for the diagnosis. And let me tell you why. If this child is sent up query Osgood Schlatter disease, we can see here that there is fragmentation in and around the tibial apophysis. But we know that happens variably, and it happens in lots of children. So what are the features we're looking for? Well, actually, we're looking for some soft tissue swelling over the top, like there is here. But actually, what we're looking for is other stuff. We're wanting to tell the GP there isn't a tumour, don't worry. Not there is a diagnosis of Osgood Schlatter, because that's a clinical diagnosis. If a child comes to you who's active, who's got proximal lower leg pain, and they're tender over the tibial tuberosity and there's a bit of swelling, then you say it's Osgood Schlatter and you get them to rest. They don't rest, it doesn't get any better, they end up coming for an x-ray. The other thing you can do is an ultrasound. Put the ultrasound probe over the tibial tuberosity, put the colour on, and it will be hypervascular. I would always do the x-ray if they ask, because that way you can rule out, or at least give them some level of reassurance that there isn't a cancer. And then the other end of the patellar tendon, we get the situation with the patellar avulsion versus Sinding-Larsen. The problem here is that the imaging findings are very similar. So you've got to rely a little bit on your clinicians and the story from the patient. So actually, this is one of the situations where ultrasound's really great, because you can ask them. You can ask them how long it's been sore, what they do, how active they are, what sports they like. Are they a basketball player? Do they like jumping sports? Are they active in that? In this case, this was an acute presentation. There's a little bit of a joint effusion, splitting of our fat planes, slight increased distance between patella and distal femoral condyles, a little bit of increased density within Hoffer's fat pad as well. And then this area of linear ossification just on the inferior margin of the patella. This is a patella traction injury, as compared to the next case, which is Sinding-Larsen, but a chronic version. And so on the lateral here, we see that same kind of appearance, but it's been going on for longer. There's more bone formation around about it. And this is a chronic Sinding-Larsen. Unfortunately, it also looks very similar to a secondary ossification centre. So you've got to rely on symptoms, you've got to rely on presentation, and using Doppler again can be helpful, because Sinding-Larsen and a chronic traction apophysitis will have increased colour Doppler signal. So those are the questions I was going to answer, which were sent in beforehand, and we've gone through those 5 cases. So we're going to put this on pause, put the music back on again, and we will have a little look at those, any questions that you ask in the chat, and answer them in a couple of minutes' time. So see you soon. It's good to be back with you guys. There are lots of questions on the chat talking about CRMO, so I thought I'd maybe answer a couple of those. So just back to this original case here. Sorry, I've got feedback from some device that's also playing me live. The edema that we see in CRMO doesn't usually have the sort of periosteal reaction that we'd expect to see with an aggressive bone tumour like LCH or Ewing sarcoma. So one of the questions was, how can we tell between CRMO, LCH, Ewing sarcoma? Well, actually, finding whether or not there's periosteal reaction is one thing. But if you are concerned, then we're always going to do a biopsy. One of the useful things is the symmetry and the bilaterality in CRMO. So if you've got bilateral symmetrical edema, it's much less likely to be a multifocal Ewing sarcoma or LCH, but it could be. What else have we got here? Question also about CRMO and SAPHO. So CRMO and SAPHO are kind of the two ends of non-bacterial osteitis. So both of them are syndromes. Both of them have this similar kind of inflammatory etiology of osteitis and are non-bacterial. They're different conditions. They're at two separate ends of a spectrum. So that's those two. What else do we have? There's a question here about whether these live streams will be available later. They're all available on the website at the Radiopaedia 2020 page. If you go to live streams at the top of the main page, you'll see links to them all down below. And if you are in a low or middle income country, you can join for free. So that probably covers most of the questions there. There's a question there as well about are there any grading systems for Osgood Schlatters? Not really. Not that I would use. I would try generally to not image children with Osgood Schlatters because you're just imaging something that should just get better on its own. The reason it doesn't get better usually is because the kids don't stop doing, they don't rest. And so you're left with a child who's not listening to the advice and doing the cessation of exercise that they need to do to make it get better. I don't see any more questions, so I think we will leave it there. Thank you for joining us. Thank you for being interested in Radiopaedia 2020. Thank you for being interested in Radiopaedia in general. It's an awesome resource. If you want to get involved, you can submit cases, you can edit articles, you don't need to do anything apart from just sign up. Radiopaedia has been built by many people, not just by a select few. And it's built because we want to make radiology resources free for everybody forever. And why don't you get involved? Tomorrow will be our last day. There are a whole pile of awesome lectures tomorrow. So enjoy them, catch up on previous. And if it's sunny where you are, enjoy the weather. If it's not, sorry, but I think for once it's going to be sunny in Scotland. Nice to see you. So long.